Hey everybody, thanks so much for tuning in to this exciting chat we have today. I have the pleasure of talking with an old friend of mine actually, and I'm not going to do justice to his introduction, but I want to gush a little bit about everything wonderful that Wil does. So briefly, Wil Dubois is a diabetes treatment specialist with the Pecos Valley Medical Center in New Mexico, a rural nonprofit clinic. He has type 1 diabetes himself and is a health columnist and author who has published over 275 articles and 4 award-winning diabetes books. Wil, thanks for taking some time to chat with us today.
It was my pleasure. It's good to see you again, Scott.
Yeah, likewise. So we have a very short amount of time to tackle an amazingly complex topic this afternoon. So I think what we've decided to do is take the spectrum of type 2 oral medications and start chewing on one piece of it this afternoon.
Better if you swallow them than chew them, actually.
That's actually yeah, maybe not the best choice of words on my part, right? That could be an interesting segment to talk about, though. Is anyway, let's,
multivitamins. Why not chewable diabetes meds, right?
It might make life a little bit easier for some people. So maybe briefly to summarize what we want to talk about today, can you talk a little bit about the complexity of the oral diabetes type 2 meds and kind of what that landscape looks like a bit?
Well, there's a whole series of categories of we sort of call type 2 orals, but in fact, pretty much all of them can also be taken by type 1s. Now, you had one particular type you wanted to talk about, which is the one type that we type 1s can't use. I'm going to make you try to pronounce it just for fun.
Yeah. So I struggle with this every time I try and say it. I'm looking at it to try and read it. Sulfonylureas.
Close enough. Yeah. We'll just call them SUs to keep it simple, okay? That's the slang.
You call it what?
SU, S/U. We'll call them SUs. That way everybody can pronounce SUs. Kind of like SUV without the V.
Okay.
So these are kind of old school oral drug. And what it does is it takes the pancreas and squeezes it like a sponge, basically. Okay, that's probably not exactly how it works, but it stimulates the pancreas to overexpress insulin production. And it sort of was one of the original go-to ways to treat type 2 diabetes. Of course, the reason it's not going to work for you or me is there's nothing left to squeeze. So if we take an SU, it's not going to have any effect. There's no insulin production to ramp up. They're kind of out of favor right now because there are essentially better things. And the reason they're out of favor is 2 things. An SU just squeezes the same all day long, most of them. There's some that are regular release and extended release, but we don't need to go into that. But if you take one and then skip a meal, you can have profound hypoglycemia. So these are kind of associated with a possible risk of bad lows, which very few oral pills are. So that's a concern. And then some clinicians feel that it may accelerate pancreatic burnout. So if we think about the physiology behind the type 2, is we've got a disease of insulin resistance. So as it stands, the pancreas is overproducing insulin day and night, 24/7, 365. And then we're going to come along and make it work even harder. Well, I think that can lead to trouble. When it was kind of all we had, it made sense because, we'll talk about metformin in a minute. Everybody's probably heard of that. That's sort of the starter drug for type 2. And when it no longer does its job, then they had to look for, well, where do we go next? And there's a belief in clinical circles that type 2s are terrified of needles and you can't possibly use insulin. That's actually not true, but it's fueled a lot of growth and development in pills because there's a belief both amongst doctors and amongst pharma companies that type 2s won't take injections. And of course, as we've seen with things like Byetta and some of the other type 2 injectables that cause a lot of weight loss, people are real quick to sign up and take those. So it's like, oh, control my sugar and lose 20 pounds? Get me started. So needles haven't been as big a problem as people believe they were. But that's off our topic. We need to stick with oral drugs. So let me back up for a minute and then let's start at the bottom. Because type 2 pills sort of like are wedding cakes. They have a big circle on the bottom and the little circles and they go on up, right? And so the bottom circle is metformin, and this is a drug that's been in clinical use almost longer than anything I can think of. It's been used for 50 years, which is pretty amazing. Aspirin has been around for 50 years. That's about all I can think of. Because even our insulins we use now are not the insulins we used 10 years ago, 20 years ago, 30 years ago, right? I mean, nobody's using beef insulin anymore. Well, nobody in this country is using beef insulin anymore. And so this is a long time for a drug to be around. Guess how it works, Scott?
We
don't know either. Nobody has any idea how it works.
That's incredible.
Yeah, it's one of these drugs that comes from the day when you took 10,000 rats and you just fed them a bunch of stuff, and you see which ones died, which ones got better. It was this very trial and error kind of period of medicine. It's not these modern things where we identify, ooh, here's some crazy little genes expressed by this little hormone, and if we can synthesize it, wonderful things will happen. So you have these very intelligent drugs now, and they didn't have that then. So metformin's sort of a trial and error discovery. It's been subject to, I can't even remember how many, I think 2,700 odd clinical studies, and nobody really is quite sure how it works. It's essentially purified French lilac, which is a noxious weed that kills cattle. So why do you think to try that? I don't know. Started in France, so sometimes you hear it called glucophage, which was the original trade name, and that's Latin for sugar eater. It does a couple things. We know kind of what it does, even if we don't know how it works. So in type 2 diabetes in particular, but in all diabetes, the liver, so back up to physiology super quick. The liver is a giant sugar battery as well as being a filter. So its purpose is to supply your body with glucose needs between meals. And so it dribbles out sugar as needed. And particularly in type 2 diabetes, but in many type 1s as well, it's kind of like a leaky faucet. There's nothing wrong with the liver, but it's dribbling sugar out all the time when it really shouldn't be. And metformin seems to fix that. So it makes the delivery of sugar from the liver more appropriate. It also is a very mild insulin sensitizer, which is really good because in people who are super insulin resistant, and maybe sort of by definition, the pancreas can't keep up with the insulin resistance, or you wouldn't have elevated blood sugar in a type 2. So that helps the insulin production remaining work a little better. And then and that often seems to happen in the lung bones, so the sort of the insulin uptake in the lung muscles, and it's a bit of a carbohydrate absorption component. So it kind of works on 3 different levels. And it's really, really effective. In fact, even though it's this little $4 generic pill, it is by far the most effective diabetes medication. I mean, it can lower, other than insulin, sorry, it can lower A1C well more than a full point, usually 1.5 points. So that's pretty dramatic. And I don't think a lot of people realize that awful lot of like the new super expensive, amazing diabetes pills, they'll maybe lower A1C 1/4 point. They're really not that super effective compared to the metformin. So it gets a lot of bang for the buck. Okay, so that's kind of metformin. Also, very safe. The few things that we're worried about early on, there's a side effect called lactic acidosis, which is very rare, but it's really bad because if it happens, it'll more likely kill you than not. But it doesn't actually appear that maybe it's a proper association. And you know how clinical research is. Somebody does something, everybody gets excited and freaked out, and then you do some more research like, oh, well, that wasn't the case. So some of metformin's early cousins appeared to have this effect. There were black labels, lots of worries. The more recent research shows what few cases there were might not have been related to the metformin, so we'll see. If it were still not a generic drug, there'd probably be a movement to remove the black box, but I don't think that's profitable for anyone. So that's metformin. That's where they usually start, and then they used to jump to the glyphosate. Now we don't see that. Instead, we've got a couple classes of drugs. The newest, I guess we could go to the newest first, are what we call the P drugs, right? The drugs like, you take this pill, and then, sorry about that, makes the excess glucose just zip out of your system. And let me turn the thought back here. Okay, so that's the latest thing is, so kidneys are designed to conserve sugar. Because sugar in nature is not a commodity, it's a rarity, and you want to be able to have it available to you. And so when the kidneys are filtering, they put all the glucose they can find back into the system. They actually pee out very, very little glucose. And then so somewhere along the line, some drug company said, well, gee, What if we kind of change that? And I'll make up the numbers here because I don't know exactly what they are, but let's say normally maybe the kidneys would dump 10% of the glucose they filter, put 90 back in the system. The idea is to create a pill that dumps 90 and keeps 10. That's kind of a scary concept to me on the surface, because what's the leading cause of kidney damage in the United States?
Diabetes.
Right. So then we are going to create a drug that is going to, you know, increase or tax in some way the kidneys. Just sort of scares me a little. So I first heard about it, I'm a little scared. The other thing, of course, is awful lot of people with diabetes have a great higher risk of kidney infections, so urinary tract infections, things like that. So the idea of trying to add more glucose to an environment where glucose sort of feeds infections sounds frightening to me. But the drugs worked pretty well. They got off to a really popular start. And then when there was a number of cases of type 2s getting full-blown DKA, which is usually a type 1 thing. It's kind of rare. It seems to be associated with the medication. And it seems to happen at a lot lower blood sugar than you would expect, like a low 200s triggering DKAs in type 2. So now a new black box warning on those. Another pill we have, speaking of things with black box warnings, there was a class called TZDs. It was like Actos and Avandia. There were these really wonderful anti-insulin resistance drugs. Type 1s could take them too, because sometimes type 1s are insulin resistant. Number of different controversies surrounding them. You know, Avandia originally kind of got pulled from the market. Later was decided maybe it wasn't such a bad drug after all. So it's kind of, it's what I like about insulin. It belongs in your body. It's a very, very simple thing. You know, you don't have to worry too much about crazy things happening with it. So we had these TZDs that sensitize insulin is an approach, and there's these pee out the extra sugar, and then sort of the last category is something new, which is going to try to make this quick. There's something called a DPP4 inhibitor. So in addition to insulin, your pancreas produces a number of other gut type hormones. One of them is called GLP-1, and this is a hormone that sort of, again, helps with the liver, it helps control digestion, it helps control satiety, and it's sort of a normal part of the digestion process. And it's co-released with insulin. And then when it's done its job, the body's supposed to release another hormone, which is what we call a counter-regulatory. So it's just supposed to stamp the crap out of the first hormone. And in type 2s, the second hormone gets out early. And so the GLP-1 never happens. So you get a double dose from sugar from the liver while you're eating, plus the stomach's going faster, you don't ever feel you ate, and it's just a big old train wreck. So there's a pill for that. That's actually the other half of the injections we were talking about, the Byetta, Victoza, those types of injections. Those are sort of like mainlining the GLP-1, and then the pill version is to try to hold back the counter-regulatory hormone. And that, if we don't talk about polypills, is pretty close to all the pills we've got. A polypill, like maybe you take some metformin and you add in a TZD to it, and you have like 2 drugs for the price of 1. Or perhaps your copay would be like 2 drugs for the price of 1.5. But so that was awfully fast and hard and dirty, but I used up half our time anyway. So where do you want to go from here? Do we have specific things? Any reader questions come in? Or, well, we're not readers, I guess, we're viewers now.
Well, so folks, if you guys have questions for Wil, go ahead and let us know, and I will, as we're chatting here, let Wil know about them, and we'll see how many we can answer. And in the meantime, maybe, Wil, you can take us through an example scenario of a patient, a typical patient that walks into your clinic. Like, what's your course of treatment as you see them and work with them? What's your first approach, and how do you?
That's a good question. Although we need to differentiate. The way we do things is probably not the standard way. So we'll take a parallel track here.
And maybe talk a little bit about that. I think that our audience is also very interested, and I'm assuming that you're talking about the way you do things is different because of the area and economics of your
No,
or
we're just smarter than anybody else. Okay, here's how we approach diabetes. Somebody walks in the door, and let's say we have never known they had diabetes before. So maybe they've shown up and like, oh, I'm tired all the time. I'm getting up to pee 5 times a night. You know, my vision's kind of blurry in the afternoon. My wife says I'm crabby as hell. So she made me come to the doctor. So that should alert somebody on the nursing staff to say, well, person's 45 years old, maybe 50 pounds overweight, and got a family history of diabetes. Maybe we should run an A1C test. So that's how people usually come to me, is an A1C test out of an acute illness, or occasionally on a random annual physical, although men in particular are quite bad about getting annual physicals, so that might be the way we would get women more often. But at any rate, so when the patient comes to me, I only know one thing. I know they got diabetes. Now, of course, there's really realistically only 2 types of diabetes. There's a whole cluster of type 2s, which would include gestational diabetes and some of the prediabetes syndromes. And then there's, so those are all the insulin resistance diabetes. And then, of course, there's the autoimmune diabetes like you and I have. But that's kind of slam dunk to diagnose, because usually somebody's coming out of the ICU, as you know. So that's easy. So we generally sort of, unless there's something really strange, we would assume an initial diagnosis of someone who's been walking around. And they back up. And if the A1C is super high, the person almost has to be a type 2, because if you were type 1 and your sugar got that high, you'd have already long been in a coma. So the opportunity to have these super high A1Cs doesn't usually happen. So a lot of times people come in and they're running 14 to 18 A1C is a really common new diagnosis A1C, so quite profoundly elevated. And a lot of doctors just, oh my gosh, we got to start something. It's like, well, yeah, you do. But the secret is there's different flavors of diabetes. So some people, their sugar is just freaking high all the time, but it's fairly level. It's really consistent. There's not much variation. Well, that's amenable to a different type of treatment than maybe someone who, maybe they wake up real high in the morning and then they're super physically active, and as the day goes on, their sugar kind of maybe even gets down to normal. And then there's other people who spike really high after meals. So there's all these kind of different glucose patterns. And I think it's best to match the medication to the pattern. So what we usually do is we sit down and tell the person, yep, this is probably the worst day of your life, but it's not over. You're going to be fine. You're not going to die. Not that much is going to change. Or that Coke you drank on the way in here, last one you'll ever have in your life. And we give people a meter and tell them to stop liquid sugar. We make no other modifications other than that. We usually see them back in a week, and we order an intensive testing pattern. So 6 to 8 finger sticks a day, really heavy duty. And then that lets me see when they come back, we can download the meter. We use the WaveSense Presto, and we can look at the data. We can show the person the data on the screen and say, look, here's what your sugar's doing. Here's where you're waking up in the morning, and here's what's happening next. So 2 things happen. We kind of can see what the blood sugar pattern is and what might or might not be appropriate. And by simply stopping the liquid sugars, sometimes that alone makes a profound difference in the people's blood sugars. Because if your sugar is high, you're going to have this polyuria where you're peeing all the time, you're getting dehydrated, it's triggering great thirst, you're drinking. If you're a soda drinker, then you're probably drinking more soda, and you have this horrible little, this little critter that chases its tail, gerbil, squirrel cage, whatever it is, yeah. So you get this, thing where the sugars can just get outrageously out of control, and they get worse and worse, and the more people drink, the worse they get. And sometimes when you're just stopping drinking Cokes, if somebody's drinking 12 Cokes a day, think about that. That's 1 every 2 hours, but I've seen that happen. And if you're taking in that much sugar and your body's not processing it right, simply stopping that, I've seen it make a 200-point difference in blood sugars. It's incredible. I've not seen it do enough. You don't have to use some kind of medicine, but you want to get it out of there so it's not interfering in the decision process. Now, most clinical places, you're diagnosed, you start metformin. Well, like we said, metformin is a really good drug, but it does its best work with this suppressing the liver. So people whose blood sugar is higher in the morning than at night, that's a good metformin candidate. But maybe someone who's largely just having a spike problem, maybe the metformin's not going to help us that much. Maybe one of the GLP-1 meds would be better. Someone who's crazy high all the time with a very flat profile, we might want to jump straight into a basal insulin. So we'll usually look at blood sugar patterns, and that will dictate the various types of medicine that will work. And then we have to sit down with the patient and say, well, what's your insurance? Because some insurances are going to cover some meds better than others, so that will let me know what my options are. And then we sort of talk to the patient about some lifestyle things, because it doesn't do any good to prescribe something that no one's going to take. So sometimes you can have a situation where you know a certain med is best, but that particular person, maybe their aunt took that drug and had a bad reaction, and they're just sure it's going to be bad news. So we always try to get a lot of open communication with the patient. And again, if somebody's needle phobic, you got to have a discussion about why that is. Maybe it's something that's real, I mean, a true phobia, or maybe it's just that it seems like it's scary. Now, how old were you when you were diagnosed? Do you remember your first shot?
I was 5 years old, so I don't remember it. I do remember it being, I remember wanting to do my own shots at a very early age because I was afraid of other people doing them on me.
Well, I was an adult when I was diagnosed, and I very much remember my first shot. It took me almost 14 hours. It took like 2 hours to get the courage to shove this needle into me, and it's this tiny little thing. You know, yeah. It was frightening. And so we often, as part of our process, we will insist that the patient take a sample, we'll call sample stick. So not a real injection, but actually put a needle on a training pen, make the person take a little shot, and then they realize that the finger sticks they've been doing at 6 or 8 a day are heaps more painful. And that can open up the barrier of discussing that. And yeah, so then we try to build a therapy plan that engages the patient trying to make a selection. So what normally happens out in the world is the person's diagnosed, and so the clinician says, oh my God, this person has diabetes, we've got to do something. And so they'll start metformin, and then they'll send the person away for 3 months, and they come back and the sugar's still crazy high, and then they'll add the next thing, like this wedding cake we talked about, and then they'll send them away for 3 months, and they'll bring them back. And so you get these people sometimes coming in from other clinics who are on like 4 diabetes meds, and they're still not under control. It's crazy. So we always try to stick to 2. You should be able to do it with 2 meds. And then we follow up a lot more closely. Some of those oral pills, though, do take 6 weeks to begin to work. So if you're using one of the class that doesn't work right out of the gate, then you kind of got to wait and be patient.
I love that approach, how you're gathering information so you can make better decisions, and then you're approaching those decisions based on the individual's medical needs, their insurance options, or what their insurance will cover. It's not what good does it do to prescribe someone something that they can't afford or their insurance won't pay for, and then also having discussions around their lifestyle. That's I really love that approach. We do have a few good questions that have come in while we're talking.
Let's address them.
All right, great. So what is your opinion on the SUs burning out the beta cells? Do you think that's actually true? What's your thoughts on that?
I do think it's generally true. That said, I've got a couple little people that have been on them forever, and they seem to be doing okay. So it might not be something universal. It could potentially be dose dependent. Sorry, I just got a message here. Okay. Where was it? So I think it could. I think for most people it does. It seems logical to me that it does. And we see these meds become less and less effective over time. Now, at the same time, the insulin resistance is growing. So, is it that the pancreatic function is declining because that's what happens in the face of growing insulin resistance? How much is the medication involved? Are different medicines in the class more aggressive than others? All those things could be true. But to me, based on what I've seen on people who've been on them and just the sheer physiological logic of it, yes, I do think they take an unnecessary toll. And I think that makes people insulin dependent earlier, which limits your clinical options. Now, of course, all type 2 diabetes theoretically ends in insulin dependence. I mean, if the disease runs its full course, and if the person isn't run over by a FedEx truck or shot by a jealous husband, they're going to need insulin.
Yeah, that's I'm just cracking up at your at the if or scenarios there. What are your thoughts on CGMs and people with type 2? Do you feel that that CGM should be more widely available, and do you think that there's hesitancy? Is there hesitancy from people with type 2 to wear them, or is it more of an access issue where insurance isn't paying for them and it's just out of reach, and some more economical barriers there?
I think it's 100% an access issue. I don't have any type 2s on CGM. I think everybody with diabetes can benefit from CGM. Not everybody could benefit from 24/7, 365 wear. I will concede that. But I think everybody could benefit. Even somebody who, say, has got an A1C of 6.2 and they're taking like half the maximum dose of metformin a day, that person could still benefit, because what you learn when you wear a CGM, you get data that you otherwise are completely unaware of. If you're doing finger sticks, and if you're on an oral pill, your insurance only gives you one finger stick a day, it's worthless anyway. But even if you buy some extras, it's very hard to understand how quickly certain foods can make you go up, how much certain activities can help you out. And so I think CGM is the best diabetes educator in the world. I think just like every person with diabetes should have access to a diabetes educator, I think every person with diabetes should have access to CGM at least part of the time. Anybody using insulin at all should have it available to them 24/7, 365, because it's a tremendous safety. I think anybody on a medication like the SUs who risk hypos should have access to it all the time. But yeah, I think everybody ought to have it. I'm yet to see any insurance company in my state cover a type 2. So
Yeah,
it's very sad.
yeah.
And they're expensive for patients, and so they're expensive for insurance companies too. But again, I think some flexible thinking about trying to match how much people need it worth versus then how much better that makes their control, which then makes them cheaper. I mean, there's an economic argument that can be made. A well-educated, healthy patient who does not have complications is money in the bank for an insurance company, and I just wish they realized that.
Yeah, it often seems very short-sighted, some of the decisions they make. So we're nearing the end of our time, and I have one question or discussion that I want to ask you about, and I'm curious. You've been working at the medical center there for a number of years. I can't remember how many.
This is my 11th year.
11th year already.
So a little over a decade.
How has your thought process or treatment approach evolved over the course of that time? And I know you as someone who learns and changes. I imagine your first year or 2 years or whatever the time was, you weren't following the approach you're following today. Can you talk a little bit about how you've evolved as a clinician over your time there?
Yeah, I've become a heretic. So earlier on, I was very much like, you got to follow the standard of care because that's what the experts tell us to do. And so, oh my God, everybody needs to be on a statin because they have diabetes, and statins lower cholesterol, and high cholesterol might cause heart attacks. And, of course, even that particular recommendation has kind of gone by the wayside. But so we used to have all these, you do it this way because the ADA or the ACE says this is the way to do it. And just in my relatively short, sometimes, 11 years on some scales is a long time, and on other scales is a very short time. But the standards have changed so much in that short period of time that I've sort of come to the conclusion that nobody knows jack shit, which is horrible. But, and also I unfortunately had the fortune or misfortune to be close enough to several clinical research projects to realize that many of them are shoddily run. And so that we have to be careful about what we take away from clinical research. And so I've gotten more and more focused, maybe almost myopically focused on blood sugar control, because we can touch that. We know that's bad. and have gotten more and more to believe that A1C is not as useful as we thought, and that the variability of glucose is more important. And that's just from seeing people with crazy high A1Cs that seem to be bulletproof supermen who never get any complications, and having people with only moderately high A1Cs that just fall apart at the seams. But the difference when I'm looking at their glucose data is how much variability there is in the set. So it just seems to me, and I know from my own personal belief, that if I have a low and then I eat too many something I shouldn't have had to fix it, and then I go high and then try to get it down again, this is back and forth, it makes me feel like crap. So if it makes me feel like crap, then maybe it's doing something bad to my body, and so maybe I'm projecting onto what it does to other people. So I really began to more and more believe that sort of, you know, glucose is the gold standard. And certainly if somebody has tremendously highly elevated cholesterol, that's a risk factor, absolutely. But preemptively putting people on a statin, which is the cholesterol drugs, the kind of gold standard cholesterol drugs, it's a wicked drug. I mean, it raises blood sugar, it can cause muscle aches and pains, it can do all kinds of weird stuff. You know, if someone's got crazy high cholesterol, yes, the evidence is very clear that that is a huge risk. But the idea of like putting people on drugs for problems they don't have yet, I don't believe in that anymore. So, and then, you know, even our blood pressure targets have changed. It's sort of it's kind of a moving target. I've got a poster in my office at the clinic from Life magazine in about 1952. And it says, you know, doctor, what brand of cigarettes do you smoke? And then it says, you know, 45 out of 50 doctors prefer Camels. And it's a genuine ad. And at the time, you know, that was the cigarette that was viewed as the safest. It had the asbestos filter, right? Had a great idea. I don't know if they were asbestos, but anyway. So I have that on my wall to remind me to be humble, because that everything I think I know today is going to be wrong tomorrow. And I probably won't even have to wait another 11 years to see how wrong it was. So yeah, I think that's the main change. Of course, in that decade too, we've got these great tools. I mean, the GLP-1, the Byetta was just coming on when I started. We've got a lot more oral pills than we had. I've become slower about adopting a new med than before. I've become more conservative. You know, it's not enough to read the clinical trial data, because I've realized that the type of people that make up clinical trials are not typical of patient populations. There's actually sort of a subculture of professional trial taker people. And so you can look at how things look, you know, in these trials done for the FDA, but when you actually get out in the world, sometimes better things happen, sometimes scary things happen. So I kind of, my mother doesn't have diabetes, but sort of one of my approach is, if my mother had diabetes, would I put her on this new drug? I mean, that's kind of how I start off. It's like, no, that's too new, I probably wouldn't. Also, we have lots of options. So if we only had one drug, that was the only drug we had for diabetes, God forbid, and then something new came on the market, well, there might be a more compelling reason to utilize it. Right now, we have a medicine cabinet full of drugs, so I'm hesitant to try something new. Of course, if everybody out there was like me, we'd never know if the new drugs would work, because they'd never get tested.
Well, brings up an interesting question. How do you, what happens to cause you to tip into experimenting, or actually that's a horrible word for me to use, right? You're experimenting with a new drug on a patient, but
so usually, you know, I like to see something on the market for 18 months or 2 years, and I like to see a situation where, for whatever reason, we are kind of at the end of the road on options. So, for instance, you know, somebody's blood sugar is creeping up, because that's what diabetes does. It's progressive, it gets worse. And we're maybe the next logical option won't be covered by the insurance, or the person is profoundly needle phobic and the next option is an injectable. And then if there is this new class of drug available, try, that would usually be how we get it. The other way, sometimes we'll have people come to us from other clinics, and they may come on a drug. And if they're doing well, I'm not going to pull somebody off of something with no evidence, unless there's evidence of a problem. So yeah, I'll then sort of observe those people and say, wow, this is really well tolerated, this person's getting great sugar, and maybe another person will come along who's not doing so well. So, well, that problem is kind of similar to what the other person was having, or what the other person told me they had before, what their historic data showed, and that can lead into testing. The new insulins, I'm a little more open, because insulin's insulin. But again, and then that's probably a topic for another day. And we've now got a whole pack of new basal insulins with a whole pack of different financial problems around them. And there can be some compelling reasons to use a few of them, and there may not be a point using some of the others. So.
Well, this has been, I've had a lot of fun on this talk. I think we could easily go on for another hour, if not half a day, talking about all of this stuff. And thank you, everybody, for your great questions that opened up a lot of different interesting angles for us too. And Wil, thanks for taking some time out of your day to help us learn more about what that type 2 oral medication landscape looks like. And based on what I'm seeing in the chat room, folks really enjoyed it. And maybe we can have you on again to talk in a little more detail about some of the other aspects of diabetes therapy. I think there's a lot of other interesting angles that we could go along to. So thank you.
Well, thank you, Scott. It was my pleasure being here. It was good seeing you as always, and I enjoyed it as well. Hopefully I didn't talk so fast nobody heard anything.
And if so, it's recorded, so we can run the replay, folks.
Slow it down.
All right, thanks everybody for tuning in. We really appreciate it, and we will see you next time.